He is. Thank you, Kristen. Of course, we know he was our governor here in Oregon, and super excited that we've had an opportunity to have him as governor. And also, he was an emergency doctor at the University of Oregon's medical school, which is now OHSU. He was a part of the legislature in 1978, and as president, he was the leader of our Oregon Health Plan, and super grateful for the work there because we still use that today. And his major contributions have been in our healthcare system here across the state. And so we're going to hand it over to Governor Kitzhaber and say, welcome. And we will definitely pin you and give you 20 minutes to tell our folks what you got going on.
Very good. Well, thank you so much. It's a real honor to have been invited here. This is a complicated topic. I'm going to take maybe 20 minutes and try to boil it down to what I think the real issues are today, and then maybe we can have a conversation about how we tackle some of these challenges. I want to start first with a story. A few nights ago, I rewatched this movie called A Few Good Men, which I'm not sure if you've seen it. It has Jack Nicholson and Demi Moore and Tom Cruise in it, but the premise is sort of this tension between blind obedience to authority and individual moral responsibility. And Jack Nicholson plays this guy named Colonel Nathan Jessup, who's the hard-ass Marine commander at Guantanamo Bay in Cuba. And throughout the film, he talks about how the Marines are in the business of saving lives. And I was struck by the fact that when I was in medical school in the early 1970s, I was taught and also believed that my job and mission was to save lives. And that came up again in a debate that some of you may remember in 1988 in front of the emergency board, which led to the Oregon Health Plan. And it was a debate over a motion of whether to fund transplants for 8 people on Medicaid or expand basic Medicaid coverage to hundreds of thousands of people who had no coverage whatsoever. And throughout that debate, Representative Tom Mason from Portland, kept arguing that the responsibility of the legislature was to save lives, save as many lives as possible. And, I got to thinking about this, and in a sense, we never really save lives in the sense that all of us are mortal, right? I mean, death is inseparable from life. They're a package deal. You don't get one without the other. And it struck me that this narrow focus on life from a biologic standpoint, which is really what the healthcare system is all about, in some ways misses perhaps one of the most significant aspects of life, which is living. And they're not the same thing at all. Life is the biologic state of existence in the time between birth and death. But to me, living is the active engagement with life, experiencing and contributing and learning and having the opportunity to find purpose and meaning, not just existing, right? Life is a noun and living is a verb. And I think our society, and to some extent particularly our healthcare system, has lost sight of this important distinction between fully engaging with life and just existing. So what does it take to fully engage with life? To me, it means that first and foremost, we all need to have the security of knowing that our basic biologic needs that are necessary for life are met: food, clothing, housing, a sense of belonging, physical security, etc. You can live from a biologic standpoint without shelter. I mean, 8,000 people tragically do it every day in Portland. But it would be difficult to argue that those people are living in the sense of having the space to wonder and to dream and to aspire and to seek purpose and meaning in their lives. For a large portion of those folks, their purpose is narrowly defined as survival from a biologic standpoint. And we know and have known for a long time that the struggle to survive, the stress of chronic economic insecurity, the stress of waking up every morning and not knowing whether you can pay your rent or put food on the table, that kind of toxic stress, both before conception and during pregnancy, can alter the genetic expression in the unborn child, dramatically increasing the risk for poor cognitive functions, learning disabilities, emotional disorders, and of particular relevance to this conversation, the early adult onset of a whole host of chronic diseases, from diabetes to cardiovascular disease. We also know that 70% of what we spend our healthcare budget on is the management of chronic diseases, most of which are preventable or modifiable. So in other words, the vast majority of what we spend our healthcare budget on And what we see in our clinics and in our hospitals are the medical consequences, the aftermath of longstanding social and economic disparities, the most toxic of which is poverty, which of course is closely correlated with race and increasingly with living in a rural community. So the point I'm trying to make here is that healthcare is not necessarily synonymous with health. And believing to the contrary is one of the central problems with our healthcare system today. Not only does it undermine the health of Americans, it also undermines the long-term economic stability of the system itself. And I have a quote here from Bobby Kennedy's campaign in 1968. It's 58 years ago that has always struck me. And he said, "Healthcare and poverty are inseparable issues, and no program to improve the nation's health will be effective unless we understand the conditions of injustice which underlie disease. It is illusory to think that we can cure a sickly child and ignore his or her need for enough food to eat." So the point is that health, being able to fully engage with life, doesn't start in the healthcare system. It doesn't start in the clinic. It doesn't start in the hospital. It starts in the community. It starts with nutritious food and affordable housing and job security and stable families and safe communities. But the relentless increase in the total cost of medical care, now 20% of our economy, undermines our ability to invest in these social and economic factors that make the healthcare system so expensive in the first place. So really, we're caught in this downward spiral. As the total cost of care increases, it constrains our ability to invest upstream, which drives down population health, increases the chronic disease burden, increases the total cost of care, and begins to undermine the stability of the system itself. Now, we don't have to accept that outcome, and we shouldn't accept that outcome. So I want to take a few minutes and try to unpack the problem we're facing here. First of all, I think it's easy to blame our current situation with healthcare in Oregon on House Resolution 1, the so-called big, beautiful bill that passed last year. And there's no question that it created a crisis. We're bracing here in Oregon for the loss of $8 billion in federal funds over the next 3 biennia. And the impact of that is going to be felt far beyond Medicaid. It's going to be felt in the commercial market as well. But the fact is that our healthcare system has been on a financially unsustainable trajectory for years. Even before the passage of this legislation, 50% of our hospitals were operating at a loss on any given day. And across the state, clinics and medical practices, particularly independent medical practices, have been just struggling to survive because of the cost of care. And that's driven a parallel crisis in access. Since 2019, the average cost of a family premium has gone up 24%. This year alone, the average increase in the individual market is going to be about 9.7% and 11.5% in the small group market. 15% of Oregonians routinely delay or forego needed care because of the cost, and the leading cause of personal bankruptcy in our state is the inability to pay a medical bill. So it's this intersection between the loss of federal funds and the escalating cost of care that's created, in my mind, this existential threat to our state. It's a threat to access. It's a threat to the economic viability of our healthcare system. It's a threat to the stability of our general fund, and it's a threat to our state economy. It reminds me of this wonderful passage from Hemingway's novel, A Sun Also Rises, where Bill Gorton is asking Mike Campbell how he went bankrupt. And Mike says, well, 2 ways, gradually, then suddenly. And things are going to get sudden. We're at that point where we're going to flip a switch, and it's going to get a lot worse a lot quicker. Now, to avoid that outcome, I think we need to recognize that House Resolution 1 simply accelerated the arrival of a crisis that we've been moving towards for decades. But instead of trying to confront it, all of us, payers, providers, labor, business, consumers, have instead been pointing the finger and blaming each other for the circumstances, right? And refusing to come together and work towards the kind of broad systemic change, which is the only path to a sustainable future. So as long as we remain in our silos, and as long as we fail to see that we're all trapped in the same failing system, we're going to continue to perpetuate this zero-sum politics of scarcity that produces winners and losers, but never a lasting solution. And that doesn't have to be our future. We have a choice here, but we need to make that choice soon, and I think we need to make it together. And that starts with a clear-eyed reassessment of the business model on which our healthcare system is built. It's not going to be easy. It's not going to be quick. It's going to require trust, and it's going to require collaboration. But I know we can do this because I've seen it before. I have seen this state come together and do amazing things that nobody thought were possible. We did it in '89 when we created the Oregon Health Plan. We did it in 2011 when we created our new CCO model, and we're called upon to do it again. So there are two central problems. One we already discussed, and that's that the system is based on this implicit but false premise that healthcare is synonymous with health. And the second problem that amplifies the first is that the way we finance healthcare in this country and in this state is based on what I call a fiscal fantasy. That is, the growing cost of care is disconnected from the resources available to pay for it. So consider for a moment that healthcare is probably the only business sector that produces goods and services that none of its customers can afford. Now think about that for a minute. The only way that works from an economic standpoint is because the cost of healthcare for individuals is heavily subsidized increasingly with public dollars. So the subsidies come directly through programs like Medicare or Medicaid, or they come indirectly through the premium subsidies in the Affordable Care Act individual market, or through what's called the tax exclusion for employer-sponsored coverage, which exempts from both payroll and income taxes the contributions that employers make to pay for the premiums of healthcare for their workers. That's about a $350 billion public subsidy of workplace-based coverage. So the point is the vast majority of people, probably most of us here, depend on some form of public subsidy to make our healthcare affordable. If you're on Medicaid, the subsidy comes from the federal government and the state government. If you're in the ACA individual market, it comes from the federal government. If you have workplace-based coverage, it comes from your employer and from the federal government. And of course, if you're on Medicare, it comes from the federal government. The point is that the business of practicing medicine or of running a clinic only works as long as the government and private sector employers are willing and able to pay these subsidies. But what's happened is the cost of healthcare has continued to go up. Both public and private payers have developed strategies to limit their exposure to the rising cost of care, not by trying to control the cost of care, but by shifting it to someone else. So both public players, states and federal government shift costs, but they do it differently based on whether or not they have to balance their budget. So at the state level, since we have to operate on a balanced budget, what happens is this growing cost of healthcare makes it more difficult to invest in education and housing and nutrition and community development and a whole host of things that have a far greater impact on population health than simply access to the acute care medical system. And eventually, they change eligibility in the Medicaid program and drop people from coverage, which shifts cost to individuals. That's the biggest threat of House Resolution 1. If we hold on to the way the system's currently structured, it's conservatively estimated that over 200,000 Oregonians are going to lose coverage over the next few years, and we shouldn't let that happen. The federal government doesn't have to balance its budget. So for decades, both Democrats and Republicans have been pushing their difficult political choices into a national debt, which is now approaching $39 trillion. So we're financing our today's healthcare needs by borrowing money from our children and grandchildren. And I leave it to you to decide whether that is an economically and morally sustainable strategy. And that brings us to private employers. So what happens there is as the number of uninsured people increases and as low reimbursement from Medicare and Medicaid erodes margins for physicians and hospitals, they shift those costs to private sector employers through increases in their premiums. The premium rate increase, I believe, that Legacy was looking for in this impasse that we just saw between them and Regency was like 28% increase. So what employers do then is they shift that right back to individuals, back to their employees by increasing co-payments and deductibles, often to the point that for all practical purposes, they're uninsured. And small employers under 50 that aren't required to offer coverage simply drop it altogether. Now, it's important to recognize that people who don't get health care don't have insurance, still get health care. When they get sick enough, they go to the emergency room, one of the most expensive care settings, and their federal laws, like EMTALA, which stands for the Emergency Medical Treatment and Labor Act, require that they be seen and treated, and those uncompensated costs then are simply shifted back to employers through the cost shift, and the cycle continues. So cost shifting is the direct response to the total cost of care, and paradoxically, the more money you put into this system, the more people become uninsured, because it drives this relentless increase in uninsured and underinsured people who can't pay the cost of their health care. And that just drives the cycle further until the whole system is on edge. So the only way to avoid driving the system into insolvency, at least in my view, the only way we can prevent or avoid eroding the very health of the people we ostensibly exist to serve, is to honestly address these two central flaws in the system. First, we need to recognize that most of the things that impact lifetime health status are outside the healthcare system. And that means that not only do we need to reduce the total cost of care, but we need to make sure that those resources are reinvested upstream in the social determinants of health and in those things that are necessary, those social and economic factors that are necessary for people to fully embrace life, which is where health starts. Second, in order to reduce the total cost of care, we've got to redesign the business model on which our healthcare system is built, including the financial systems that underlie it, and identify these external factors that also drive medical inflation, things like the cost of prescription drugs, labor and workforce issues, regulatory overhead, and our very fragmented and inefficient and actually ineffective behavioral health system. Now, describing a problem without offering a way to address it is not leadership, it's whining. So you won't be surprised that I have some fairly well developed ideas on how we proceed from here, and I'm engaged in some of those efforts. And hopefully we can discuss that here in just a few minutes. But before we do, I want to add just one final thought, and I apologize if I've gone rapidly here. I just want to make sure we've got plenty of time for a conversation. As I mentioned, for decades, we've been able to avoid this crisis, even though, if we're honest with ourselves, most of us have seen it coming. And we've been able to avoid it by kicking the can down the road through cost shifting and debt financing. And I submit that those strategies have come to an end. Their viability has come to an end. And if you think about it, today we're pinning the future economic stability of our healthcare system, 20% of our economy, one of the largest employers in the state and in many rural communities, and it's the single largest employer. We're pinning that system in its future on two risky bets that no sane bookie in Las Vegas would ever take. The first bet is that private sector employers are going to continue to passively accept double-digit year-over-year rate increases. And I would argue that this recent impasse over rates between legacy and Regents is a case in point. Suddenly 9,000 people were out of network. And that's going to become the new normal if we continue to cling to this failing business model. The second bet, which is even riskier than the first, is the bet that the federal government is going to continue to borrow heavily from future generations, from our children and our grandchildren, to finance today's healthcare needs. Given the fact that our national debt is already $39 trillion, doubled since 2015, given the fact that our debt to GDP ratio is 120%, when most economists say when it gets up to about 90, it starts to be a drag on the economy. And given the fact that people like Jamie Dimon, who's the CEO of JP Morgan Chase, are saying we can't avoid a serious bond crisis in the future, I think this bet is not only risky, I think that it is mathematically impossible. But we don't have to accept those bets. We don't have to accept those bets. Oregon has this long, proud history of shaping its own healthcare future, regardless of what's going on in the federal government and what's going on in other states. And we're called upon today to do that again. So we're at an inflection point. Things are going to get sudden. This inflection point is not years away. It's probably months away. That means we need to choose, because we're running out of time. We need to choose whether we're going to falter and continue to blame one another for our current circumstances, even as the current swiftness takes us all towards the lip of a precipice, or whether we're going to rise and meet the challenge and together, in the heat of the crucible, forge the leadership that this moment demands. I know Oregon and I know Oregonians, and I'm betting on leadership. Thank you very much again. It's an honor to have a chance to talk with you today.
Thank you so much for that. So first of all, you dropped so many nuggets. I was just writing notes like I was back in school. And my first thought when you were talking was, I wish I lived here when you were governor, but that's another subject. But awesome, just nuggets that I just want to bring back into the space as people can put questions in the chat if you are interested in asking specific questions. But you started off by talking about, life is a noun, living is a verb. That is such a powerful way to look at the healthcare system, right? Because I think we automatically go to, how you get served in a hospital, what's going to happen if I'm sick as healthcare system. But the reality is that we all deserve an opportunity to be living at our best, whatever that is for each one of us, right? So I really, really love the way you frame that. And you frame so many things beautifully, and I can see why this is the world that you live in and it's your expertise. And so my first question to you is around that kind of living versus life. For communities experiencing chronic stress from poverty, unstable housing, and healthcare costs, what does a system designed for living actually look like? And what fundamentally must we change as we come together to really start thinking about that?
Yeah, that's a great question. And by the way, I do have a speech I gave a couple of weeks ago to the Marion County Medical Society with some slides that has a lot of this in it, and I'd be glad to send that to you if that would be useful.
Yeah, please do. We'll make sure folks get it.
Okay. So this is going to sound oversimplistic, but I believe that the vast majority of problems we face in our society today come from the fact that a growing number of people simply lack the security of being able to meet their basic needs. And we all know that that kind of chronic stress drives up cortisol levels. I think some of your questions relate to this. It's that stressful environment of insecurity is what drives most of the things into the healthcare system. At least 90% of what we pay for is managing chronic illnesses. So I think that first flaw that I mentioned, this presumption that healthcare is always synonymous with health, is really important. It's almost a cultural shift. We have to begin to think that what we really want is health. I mean, we all need access to healthcare, but no one really wants to be a patient in a hospital or a patient in your healthcare system. They don't want that. They want to be healthy. They want to function and have opportunities to dream and to contribute and to be their very best version of themselves, whatever that looks like. So I think we have to change that frame. The other thing, and I'm trying to quantify this, write something that sort of quantifies. It's not that we pay for it now or we pay for it later. We can not provide access to good, solid prenatal care. In some Scandinavian countries, women who've just delivered, they don't work. The family is together, and that's such an informative period of time, that first 1,000 days when those relational health is developed, those connections are developed. So it's a matter, really, the political challenge is getting people to understand that, and second, trying to figure out a way to reallocate resources from the back end to the front end. And I remember this in that debate in 1988. It's what led to the Oregon Health Plan. If you're a legislator and you have a choice of resuscitating 500-gram infants in the neonatal and intensive care unit, or giving tens of thousands of women access to prenatal care so that they don't have low birth weight infants in the first place, the political and emotional imperative always drives money out of the community and into the hospital. So that's the conversation we have to have. And let me just end with this. There's a guy named Kent Thornburg, Dr. Kent Thornburg, who runs the Moore Center on Nutritional Health at OHSU down in the South Waterfront. His expertise is in the impact of high cortisol levels and stress before conception and during pregnancy. And he's got a slideshow that would knock your socks off. And if you ever want to, he'd be a really good person to present, I think, on the policy side of this, because the science is there. We know it's there. We're just not using it in our policies.
Yeah, thank you for that, Nate. We'll definitely reach out to him. And thank you for that answer. It's always interesting to me when we have brilliant leaders that are in the right spots and doing the right things. But it's interesting to me how they think, right? Like, you think in a way that helps us reframe and helps us get grounded in opportunity, right? Because a lot of times we spend a lot of energy in our day on what is not happening and how it makes us feel, and it gives us anxiety, and oh my God, it's so much, and it's so heavy, right? But great leaders help us reframe and reposition our energy towards something that is possible. And so I really appreciate the way that you're framing this up for us. And I also want to connect it to, like, we are big. That's why you bringing up Kent Thornburg is huge for us. We believe at Women's Foundation of Oregon that our nonprofit leaders who are carrying a heavy load right now in the work that they're doing for society to thrive, those external factors that often land in our healthcare system, we believe that if we give those nonprofit leaders rest, then they have the space to begin to dream again, right? And so with exploring that idea and the fact that rest is not a luxury, because we know that it has all these other factors that come with us not resting well, there's an infrastructure to it that is really grounded in healing and also decision making in our theory of change. And so from your perspective as a physician and a policymaker, what would it take for a system to begin to treat rest of our most the leaders that are carrying the heaviest load of this justice work? What would it take for our system to begin to treat rest as a legislative public health strategy?
Yeah, well, it is. There's no question about it. And it's we've got a little group on behavioral health and substance use disorders that we're working on as part of this solution here. We were having this conversation this morning about frontline behavioral health workers. It's really hard work. And part of it is this moral injury of not being able to help the people that they're serving, right? I mean, they work with the system. The system it's this fragmented system. And so they just get burnt out. And it's terrible. We saw that during the pandemic. We've never really recovered. A lot of our healthcare workforce has never recovered from that. So I really do think, and again, I don't want to sound simplistic, but we really need to recognize that chronic stress from whatever source is toxic. It is a driver of the pathology in our healthcare system. It's a driver of kids who are failing in school. And we need to view that as a public health emergency, as a public health element, that if we don't address that, we simply cannot ever afford our healthcare system, which is going to suck more and more money out of other important investments like equal opportunity and education and all sorts of other things. So I think, again, it's this cultural change. We need to begin to talk about the fact that the suite of factors that mitigate or help prevent chronic stress from whatever source are just really unhealthy. And we don't even acknowledge that. I mean, when I was in med school, we didn't even talk about this stuff. I don't know what the curriculum's like now, but yeah. Our system basically fixes broken people. You stay in your clinic, you stay in your hospital, and people come to you. We do nothing as a system to prevent them or address the circumstances or the conditions of injustice that drive them into the healthcare system in the first place. And to me, that's just wrong.
Well said. Well said. I mean, that whole little section that you said, I'll be repeating that over and over again. We also think that, in our world, not only recognizing rest, but also recognizing that when that rest happens, that we get dreamers again, right? And we get people who start to come up with solutions because they're not in this toxic kind of zone of their life, right? So what are your thoughts about the healthcare system and using dreaming as data?
Well, I couldn't agree with you more. I mean, I think there's so many really horrible consequences and tragic consequences of ignoring the very beginnings of life, which is where the foundations of living start, right? I mean, that's where you get behind in terms of health, et cetera. And I think that one of the real tragedies of poverty is that if you're every day, if you wake up and your preoccupation is having a house, putting food on the table, being able to spend time with your children, particularly when they're young, you don't have the space to dream. you don't have the space to dream and think and make that your own unique contribution to the fabric of our society, which is, to me, only as strong and rich as the number of people and diverse people who can actually contribute to the weaving of that fabric. And so I think, there's a guy named his name is Robert Reich. He was the Secretary of Labor, I think, under Bill Clinton. But he wrote this essay called the Loss of the Democratic Narrative, and he talks about these, in particular, two narratives that have been threaded together since the beginning of our nation. One is this notion of the triumphant individual, that we're all independent, and that if you fail, it's because you didn't work hard enough. So like failure or poverty is a personal and moral failure. Then there's the benevolent community, which is the tension point, and that basically believes that we're all in this together, and that if you fail, it's because it's all of our failure. It's a collective failure, and all the data and the evidence suggests that that's the case. But since Ronald Reagan, who really was the one that sort of changed that political narrative, there's that tension going back and forth, and we need to take that on. We need to take that on and say, if we want our country to be strong and united, we need to make sure that everyone has that opportunity, that space to dream and to contribute and to be all that they can be. And I think part of what's going on today is when you feel trapped in a low-income job with no way up and no way out, you become susceptible to the kind of demagogic populism that we're seeing today, the politics of blame and the politics of shame. We're so much better than that, and we ought to be better than that in Oregon. And I just think we need to start talking about that more. And it is the core of the healthcare system. The healthcare system ought to be designed to put itself out of business.
Agree. I say the same thing about nonprofits, that we should not be in business forever. We should actually be putting ourselves out of business. If we were offering the finite answers that we needed, then we would not be in business, right? Because we wouldn't be needed. So totally agree with that. We've got one question in the chat that I'll ask you, but if anyone else has a question, please put it in the chat. So the person says, Darla says, thank you so much for amazing information. What is your perspective on the plan for universal health care in Oregon and whether or not the governance board will be able to present a viable plan in September this year?
Yeah, great question. And Dr. Helen Belanca, who is the chair of that governing board, is on the work group. So we're sort of wired in with them. My own personal, I don't have any problem with single payer. I don't have I do think we need to decide to define what we mean by universal health plan, because it's a pretty general term. My only concern with and I do think there's certainly some efficiencies with a single payer system because of the complexity of our payer system right now, our insurance system right now. At the same time, if all you do is change what you pay for, change how you pay for a dysfunctional system, you haven't solved the problem. And so my hope is that in whatever they recommend, they talk about some of the things that we have been talking about today. You could have a single payer system tomorrow, and if the incentives within the system were for acute care management and not making those kinds of social and economic investments on the front end that drive health, you would have a more efficient health care system, but you wouldn't address, I think, overall population health statistics. So I'm working closely with them. I've had the opportunity. I was invited down to speak to them. So I don't think I don't think it's the end. What we want, it seems to me, what we want is we want a system where everyone has timely access to quality, affordable health care that's appropriate and effective. And so I don't care, to me, that's the end. And there's probably a lot of ways to get there. And I think what they're debating is one particular way to get there. So we'll hope they come up with some real interesting innovations.
Great answer. And I love the again, perspective. And I think that's our point here. This committee is giving the folks that come and join us here, not necessarily answers, but a new way to critically think about what's happening so that in their own ecosystems with their experiences, they can contribute to those things in a way that brings the brilliance together. Because I agree with you that as daunting as this moment may feel for many of us, many daunting moments in our country and our history have been the moments that we've designed the most brilliant solutions, right? And so, but we must do that together, right? Like it's not a one person assignment. It's all of us bringing our brilliance into the space and understanding that. I don't see any more questions in there, but I've got plenty. So, so if you guys have questions, please dig in there. Oh, I see another one. Thank you for being here today and sharing. My question is, how do we shift the narrative to being upstream and have communities where we are preventing the chronic stress you are talking about? And that's from Laura Hall.
Yeah, we just finished, we created an organization a couple of years ago called the Oregon, what was it called? Oh, heck, Oregon Health and Education Collaborative. And it had some really interesting leaders on it from both from education, from healthcare, et cetera. Kali was Thorn Ladd, if you know Kali, of course you know Kali, everyone knows Kali, was on our board. Eric Hunter from HealthShare. We had a bunch of school superintendents. And our project was called the First 1,000 Days Upstream Initiative. And the goal was, we had, I think, 5 pilot projects. And the idea was to create a locally designed, locally owned, locally managed delivery model to ensure that every pregnant woman in that community knew exactly where she needed to go to get everything she needed for herself and her family to make sure that her child thrived, at least for the first 1,000 days of life. So the one's still operating in Southern Oregon, one's operating over in Northeastern Oregon. We tried to get the legislature to fund those because we just raised private sector money for these things and foundation money, but and they didn't do it. So I think that part of it is you have to somehow change the mindset of our legislative bodies, which really operate on a 2-year event horizon. None of our problems, whether it's this problem, education outcomes, healthy forests, you can't solve it in 2 years. But what happens is we operate on this 2-year event horizon that's bracketed by these increasingly toxic and very partisan election cycles. So it's really hard for long-term policy to get implemented. One of the reasons we passed House Concurrent Resolution 202 that I think you referred to was we want to say, okay, in 6 years from now, this is what we want our healthcare system to look like. That gives you the ability to look at individual policy and budget decisions over 3 biennia and say, that's taking us away from this, not towards it. So it creates a context. And I do think it's that kind of thing, which we don't do well in our political system in the United States, but it doesn't mean we couldn't do it. Yeah.
Yeah, I so appreciate that House resolution. I was able to follow it as you were presenting it, and I'm really happy that we have it because I agree. In order for us to find answers, we have to start looking further down the line and looking at a longer runway so we can have kind of that North Star, that we are aiming for. And we all collectively will contribute to it in a different way, right? Like we will all have different pathways, but all of the pathways are leading us to this one destination. And we're really clear on what that is. With our work at Women's Foundation of Oregon, we've been like collecting dreams and creating things we call Abundance for All legislative review, where people can look at things of where our community wants to go. And so we're looking at our candidates and looking at our bills from that lens. Like, does it get us closer to that? Not necessarily answer all the questions, but does it get us closer to it? Or, what work do we need to do? What questions do we need to ask in order to get there? So really appreciate that also. And we'll keep following that resolution and what comes out with it. You described the healthcare system as one of the only sectors where the product is unaffordable, which is a brilliant reframe, unaffordable to the customer. Without subsidies, obviously, we don't have healthcare. If we accept that as our reality and understand it, does that mean that healthcare should stop being treated primarily as a market commodity, or instead should we design more of a public infrastructure? What are your thoughts on that?
I think healthcare is a public good. I don't think it should be treated as, and unfortunately, our system does treat it as an economic commodity, but it really isn't. And part of the politics of unbundling that is there's a whole lot of folks who are invested in the current system. That's true with everything. I mean, one of the reasons I gave this talk a while back that upset some of some of my friends, but I was asking, the question I was asking is what could progressives have done to create the environment that allowed someone like Donald Trump to get elected in the first place? And part of it to me is not progressive values. Part of it to me is we continue to try to use these old institutions and structures that were designed in the middle of the last century to deal with a new set of problems. And each one of those institutions has a constituency that doesn't want to change it, right? And so it requires leadership to say, look, the problem isn't the people in the system, the problem's the system they're in. Let's fix the system. And again, that takes a number of years to do that. But yeah, you're spot on. The healthcare system is and the way to put the way to reduce the cost of the healthcare system is to reduce the number of people who need to go to the healthcare system. We treat our cars better than we treat our people in a lot of sense. I mean, you go in and get your oil changed, or you have a knock on your car, you're right down there getting it checked out. But that's not true. And the other thing that's really difficult is that the investments, let's say you're going to really seriously invest in the first 1,000 days of life, or in that perinatal period, in all aspects of investment, you don't see an ROI in the course of a 2-year budget. You're going to see that ROI for sure, but you're going to see it 4, 6, 8 years downstream, and I think that's a challenge to figure out how you keep that continuity in a legislature that deals primarily with crises.
Yeah, that's an interesting concept too, because I often think about my grandparents were really good at like having this understanding that what they were doing in the moment wasn't necessarily for their lifetime. And some of that was extreme crisis, right? Like in particular in my Black American family, like they knew that I was going to see things that they never saw, and it excited them, right? And it didn't pull them back from doing that work or make them do less of it. It made them do more of it because it was okay for them to not see it. And so I really want to understand, like, how do we get that mindset back for people? Because everything that we're doing matters. If we're willing to borrow from our grandchildren, then we should be willing to give to them without seeing them. Does that make sense?
Makes total sense. I don't know who said this, might have been G.K. Chesterton, but something to the effect that children are the messengers to a future we won't see.
Mm-hmm.
And what is the message we want them to carry?
Yeah, so true. It's so true. And I carry the message from my grandparents now, right? And I'm honored to carry that message. So I would want the same for our future children, right? To be honored to carry whatever we're coming up with. I can go back and forth with you forever, but we got more questions in the chat. Thank you so much for sharing all this information. The question is, many women are still carrying the invisible burden of sustaining families while navigating fragmented and expensive healthcare systems. What would healthcare system look like if it truly invested upstream in women's lives, housing, nutrition, safety, mental health, and community support instead of waiting until crisis?
Well, I guess it would be a health system as opposed to a healthcare system. I would think create the incentives to make those kinds of investments. Part of that is, what do they call it? Pay for performance. I mean, we know, for example, and I'm not nearly smart enough to do this. Maybe Rakai Adams could sort this one out. But it seems to me that we know that those kinds of investments, early investments, pay off, I don't know, 7, 8, 9, 10 to 1. It's huge if you actually make those early investments. So the question is, how do you monetize the cost savings, prospective cost savings, and put it back on the front end? And I do think that's part of it, changing those financial incentives. And it's a process, because I call it the front end, back end problem, right? So we know we need to invest on the front end, but we also have individuals who are in crisis and need help now, and you can't ignore them. So somehow you have to be able to invest in both at the same time, which is difficult, obviously, until the front end catches up to the back end. What we try to do with the CCOs, and maybe this would be a better answer to your question, you can't pull a huge piece of the healthcare system resources out suddenly because the system collapses, right? Because it's the wrong business model. But what we tried to do with the coordinated care organizations is the commitment to the federal government to get that $1 billion that we got to make the transition was we were going to reduce the rate of growth by 2% below what it currently was. So it was 5.4% in 2011 when we did this, and we promised to drop it to 2%. The idea then was to take those cost savings and reinvest those back on the front end, right? So that so it's a reallocation a challenge. The problem is we don't have a community-based infrastructure that can actually ensure that those dollars, those reinvestment dollars, get to the right family and the right children at the right time and the right amount and long enough to get the job done. That's what the first 1,000 Days Upstream initiative was about. But it would be a system that values health, where the acute care medical system is viewed as not a place you want to end up. And this is if there's any financial people on this call, this would be one to noodle on. Our healthcare system is now almost $5 trillion a year. What if you could create some economic model that says if you can reduce that cost trend by 5 or 6%, you get 0.5% for your equity capital? I mean, all of the investment is in new technologies, new little delivery systems. They're all additive. Nothing goes away. What about investment in innovation for cost savings, for improving outcomes? It's sort of alien, I think, in terms of where we put our money and our resources. If you think about the system, all the incentives and all the investment is in institutional care and specialty care at the expense of primary care and community-based primary prevention.
Now you got my mind thinking. Innovation for cost saving structures. I love that. I think that might be we're kind of noodling with that, but how do we make it more intentional? I think that's, really interesting thinking. Another question from Liz is, how do you consider family or care providers that are caring for children and elders with our fragmented healthcare system?
Is this specifically elders who are helping care with children, caring for children?
I think they're talking caring for children or caring for elders.
So that is, there's a term for this that I can't bring to my aging mind here, but that's a huge part of our workforce that's not compensated. It's a community asset, and it's extraordinarily important and valuable asset. And I do think that there should be a way to compensate people for doing that. I mean, it is a huge unpaid and unrecognized workforce, and if that went away, I mean, I did it with my parents for quite a while as they were getting elderly. You all know Jay Bloom, I'm sure, the hyperactive Jay Bloom, and his work, his intergenerational work that he's doing. I mean, the whole idea there is actually to try to re-engage all ages, across all ages, in a common effort to make our communities more generous and more sustainable and more compassionate. And I'm sure that group has got some well-developed ideas on that.
Love that. Another question is, you described how rising healthcare costs constrain our ability to invest in upstream and very conditions that create health. In practical terms, what policies or financing changes would allow community health centers to move beyond being safety net providers and become true drivers of public health improvement within Oregon's next OHP model?
Yeah, so that's a great question. We do have a subcommittee that's working specifically on primary care and that includes obviously the safety net clinics, community health centers. I think that's one of the problems we've got today is that we have underinvested and undervalued our primary care infrastructure. One of the things that, if you probably looked at when the OHA made a decision to sort of raid the quality incentive pool in this last budget, those were the resources that actually were going to primary care clinics, those incentive dollars to actually help stabilize them. So we're hoping to come out with a really robust strategy, six-year strategy through biennial strategy to revitalize primary care. Part of it is to change the payment model, because, when I was growing up, when I was doing primary care back in the day, I was just doing primary care. We didn't do any of those. We didn't have social connection with social services, right? We didn't have bilingual people there. We didn't have behavioral health right. And now that's part of the primary care, the patient-centered primary care medical home is the model I think that we want to foster. And right now we don't value it and we don't pay for it. And we need to do that. That's going to be a resource allocation issue. But I think if we can see this as a long-term effort to improve overall health and stabilize the entire system, that we can make that happen.
Yeah, I really, really appreciate your words of wisdom and your perspective on all of these things. And so I want to close so that we make sure that we get everyone back to whatever they were doing in a timely manner. And we always close with the same question, which is, what is your dream for Oregon that you would like to share with us and that we can also carry forward as we leave today?
Well, my dream is based on a deep belief that Oregon won't be a good place for any of us to live unless it's a good place for all of us to live. And I think that is a North Star and a lens through which we should look at our policies and our politics. Let me just say it's been a true honor to have been invited. I don't know where that came from, but I'm so honored that you let me speak to you. I will do two things in follow-up. I will send you the speech I gave down there in Marion County, and then I will connect you with Dr. Kent Thornburg in case you'd like to have him come up, because you would love that conversation, I can guarantee it.
Yeah, I would love that connection and also the slides. And we'll make sure that everyone here gets the slides also so they can learn from that. And please keep us posted. We learned about you because of the resolution. We follow, part of our work is policy advocacy. We do grant writing, and then also public policy advocacy and research. And so in following that resolution, we have a dream here around creating a clear definition of what justice looks like for all by 2033. And so that draw our eye to your resolution. So we're excited to keep following that. And hopefully you'll follow our work around gathering dreams, because dreaming is data. And we believe we'll find some answers to some really tough times for all of us, but we can do it together.
We can.
Yes.
Thanks so much. Appreciate it.
Thank you for your time, and thank you everyone for joining us as usual. We're always happy to see you here. We will follow up with all the things that we said we would send you. And please, please be safe, rest well, dream boldly, and don't forget that we're in this together. Have an incredible day, you guys. Thank you so much.